So good afternoon, and that was an interesting prelude by Dr. Chandrima about the treatment of glaucoma and diurnal curves, and I would like to take you on another track to talk about the maximal medical therapy in the Indian setup. As we know that we are aiming to treat the glaucoma. The European guidelines say to maintain the visual function with a related quality of life and cost. And the American Academy says to stabilize the optic nerve and the RNFL status and to maintain a stable visual field. So that is our aim in treating glaucoma. As we know, the intraocular pressure is the only modifiable risk factor, and it has to be managed by medical, laser and surgery therapy. The goals of therapy that we do is achieve a target pressure, reduce the IOP fluctuations, as Dr. Chandrima said, administer glaucoma medications which have the least side effects and affect least to the quality of life of the patient. Achieve the treatment that is affordable and sustainable in cost for the patient, monitor the structure function of the optic nerve, treat the non-IOP dependent risk factors such as low diastolic perfusion, diabetes, lipid and vasospasm, which may additionally contribute. And very, very important is educate the patients and his family as far as the method we are going to treat the glaucoma, and that it is a lifetime treatment and what they can expect as time goes by. As we know, we fix the target pressure. Dr. Chandrima has already shown us how we are going to do that. We are going to consider the glaucoma damage, the life expectancy, untreated pressure and additional risk factors, and last, if you know, the rate of progression. And as we know, we are going to set the target pressure based on all these factors, but all show that lowering intraocular pressure is the key. And we have various drugs classes which are available to us in India today, that is prostaglandins, beta blockers, alpha agonists, carbonic anhydrase inhibitors and cholinergic drugs, which is available to us. There are some new class of drugs which are coming up now, but not yet come into India. If you consider the efficacy of each of these, the prostaglandins are by far the most effective, which reduce intraocular pressure by 30 to 35% from baseline. The beta blockers and the alpha agonists are somewhat comparable, coming in the 20 to 25 range. The carbonic anhydrase is the weakest, comes into 15 to 20%. The cholinergic agonists, that's the pilocarpine, they can increase by 20 to 25, but I would add that would also depend on the structure of the angle, and patients who have some amount of angle closure seem to respond better. Time out already? He says time is out. I don't think 15 minutes are out. I think it is the time out of the previous session. So you please just adjust the timing correctly, because there this guy puts up a board saying time is out. As Chandrima pointed out this algorithm already, I am going to skip that. But very important is that what is the point of treatment when you are going to give so many medications? Are the patients putting the drops correctly? And you can see that when you have more than 2 IOP lowering agents, how many patients are actually putting on monotherapy. Even in simple ocular hypertension, where there are no glaucoma changes, only pressure is high, 40% of patients need additional drops in the first 5 years. So the amount of drops we need to use for the patients who have moderate glaucoma and severe glaucoma, you can imagine that a lot of percentage, going up to 75%, require more than one group of drugs to be used to control their glaucoma effectively. And we have to consider how do we add a second drug. So if the monotherapy is not enough, then we are going to think of adding, but we must consider the drug which is having an additionally different mechanism or a complementary mechanism of action before as to choose as the second drug. So if you have used an outflow drug as your first drug, then use the inflow drug as the second additive, and recommend that the treatment complexity, adherence and washout effect are taken care of. And now we are very, very conscious about exposure to preservatives. When we increase the number of drops, if all the medications have the same preservative, then amount of preservative going in the eye seems to be going up many-fold, and that is very important because it has detrimental effect in the long run. The drug absorption, if you put the second drop very close to the first drop, it has a kind of washout effect, and that reduces the efficacy of the first medication. So there has to be a good interval between two successive drops. Non-adherence is definitely a big problem, and if we are using two separate bottles, more number of drops, and we have good studies to show more the number of drops, the bigger the problem of compliance and adherence, and therefore fixed drug combinations seem to make a good sense. Dr. Chandrima mentioned this in her talk, and these adherence rates eventually impact the stability of the fields. So non-adherence leads to poor compliance, leads to progression more rapidly than if we are getting better adherence. So fixed drug combination definitely reduces the complexity of the treatment and gives you potential benefit of additive efficacy, preservative exposure reduction, tolerability being better, dosing frequency being more comfortable, so you get better adherence. Because of the inherent advantages, you have fewer drops and you have a single bottle with multiple drops. This is definitely the way to go when you know that you need more than one drug. But most important thing, as Chandrima pointed out, when you are going in for treatment with more than one drug, you should be particular that each additive medication you are adding to the regime should have a therapeutic benefit, and you have to see that before you start a fixed drug combination. The guidelines, whether it's the European Glaucoma Society or the American Academy, say that there is rationale in the studies to support the decrease in the number of applications per day and thereby increase the compliance, and they support the use of fixed drug combinations. Today in the market you get fixed drug combinations, all of which were mentioned by Dr. Chandrima. They contain the beta blockers except the beta blocker carbonic anhydrase combination, that is brinzolamide with brimonidine. All the other three have beta blockers in them. So with each of these drugs you are getting additive effect and they are increasing your efficacy. So how far are you going to go? What is the maximum number of drops you are going to give a patient? That is what constitutes maximum medical therapy, or MMT as it is called. It is defined as the achievement of the greatest possible IOP reduction with the largest number of medications that a patient can tolerate and is willing to be compliant to administer regularly. So different factors vary from patient to patient. You cannot have the same formulation for everybody, which constitutes MMT. A simple regime could be not interfering, minimum interfering to the patient's quality of life. And as I said, you have to make sure before you start maximal medical therapy approach, you have to be sure that each of these drugs is working for that patient. Second is that he or she is going to be able to maintain that same dosing schedule for a long period of time without complications and without getting affected in the quality of life too much and financially. These three factors you have to keep in mind. So the PG analogs, beta blockers, alpha agonists and carbonic anhydrase inhibitors, when used all together, they are additive to each other. We know that from many studies. But as I explained earlier, you have problems of dosage and schedule, preservative exposure, ocular surface and cost, and that is reduced by fixed drug combinations. So when you have a maximal medical therapy scenario where you are going to use, you definitely need to use fixed drug combinations in your formulation. The physician, before starting maximum therapy, is going to consider the side effect profile. So you have to be sure that each component side effects are not occurring in that patient, and try to organize in such a way that you just have drops morning and evening, because afternoon or midday drop installations definitely are proven by many studies to have poor compliance. And if you are not able to get a proper regime for this, opt for a laser or incisional surgery, and the approach has to be individualized for each patient. So you have an option one where you have the combination of a beta blocker and a topical carbonic anhydrase inhibitor with a topical prostaglandin analog or brimonidine. So that is one combination of a maximal medical therapy. Or you can have a PG analog with a BID fixed dose combination of timolol and a BID fixed drug combination without timolol. So you can use these. The last, and which we are now talking about, is the PG analog beta blocker combination with a brimonidine and alpha agonist and carbonic anhydrase inhibitor, that is brinzolamide combination. So you have 2 bottles, each having 2 drugs. So you are getting 4 drugs in 2 bottles, and it totally comes to 3 drops in a day. And there are many studies which have shown that these combinations are effective, and in the interest of time I am going to just rush through them. The most important thing is that these quadruple combinations, where you are putting 4 drugs, have many possibilities. You have 4 molecules in 3 bottles, or sometimes 4 molecules in 2 bottles, and they are easier to administer, and there are studies to show that this is definitely working in a small percentage of patients, and that is definitely an option which you can think of in your daily practice with complicated glaucoma patients who need more medications. In summary, glaucoma is a multifactorial optic neuropathy, leading causes of blindness in the world. The primary factor, which is intraocular pressure, elevated intraocular pressure, can damage the optic nerve head, and this is the only treatable factor. Clinical trials have demonstrated the benefits of IOP reduction in reducing risk progression in established POAG. And in the last decade, there is a paradigm shift, and now we are increasingly using PG analogs instead of beta blockers as your first line, and substantial portion of patients require more than 1 drug. Up to 75% of patients are going to need more than 1 drug for adequate control, and that's the time when fixed drug combinations come into place by improving the dosage schedule, reducing the exposure, taking care of the washout effect, getting better outcomes. There are situations where you require more than 3 drugs to manage the glaucoma, and you have to consider the maximal medical therapy scenario and get the maximum possible IOP reduction with the maximum number of drops that you can tolerate and afford and administer regularly. The true MMT uses one choice of each available class of anti-glaucoma medications. Different factors vary from patient to patient to determine what is MMT for that particular patient. Because prostaglandin analogs, beta blockers, alpha agonists, topical CIAs are additive, they can be used in conjunction and interchangeably. Treatment has to be tailored to the individual patient before going further. Thank you.